Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
My name is Bill Robbins. I'm a general dentist in San Antonio, and welcome to my practice inspiration. I'm going to be speaking with you for the next few minutes about interdisciplinary dentistry. Anytime we discuss interdisciplinary dentistry in my world, it starts with this, the 4 global diagnoses. My partner Jeff Rouse and I have been working on this information for more than 2 decades, and so the 4 global diagnoses, in our opinion, dictate all interdisciplinary treatment planning. The first diagnosis is related to the upper lip, the second to the clinical crown, the third, dentoalveolar extrusion, which means supereruption of the teeth, and the fourth is a skeletal discrepancy. And of course, a patient can have more than one of these going on at the same time. It turns out that once you make a global diagnosis on a patient, you only have 6 tools in your bag of tricks to fix any tooth, gingiva, face problem. And so that's what we're going to talk about today. The subtitle to this presentation is what the periodontist, the orthodontist, and the oral and maxillofacial surgeon can do for me as a restorative dentist. Traditionally, many years ago, we were taught to treatment plan patients that we're doing interdisciplinary dentistry on the articulator with a condylar position that was generally centric relation. We no longer treatment plan that way today. Now, I'm not diminishing the importance of centric relation or a condylar position, but today we use facially generated diagnosis. Thanks to Coys and Spear and others, they taught us that instead of starting back here, we need to start here to determine where the teeth should be in the patient's face. And obviously this is based on incisal edge position of the maxillary anterior teeth. So if we're going to start with incisal edge position, then obviously we need some guidelines to lead us through that determination. So these are our 4 guidelines to determine the new incisal edge position. The first 2 are determinants. The second 2 we use to confirm. So the first is the incisal edges of the maxillary anterior teeth should be cradled by the lower lip in full smile. The second guideline is that we want to step up from front to back or a step down. The occlusal plane should be level from front to back. Those are the 2 primary. The 2 confirmatory are the incisal display and repose. We remember is 3 to 4 millimeters in the young female, a couple of millimeters less in the young male, and less as the patient ages. And then finally, we want to make, obviously, the teeth anatomically correct, and we remember the average length of the central is 10 to 11 millimeters. We're going to do a diagnostic wax up based on these 4 guidelines. We're then going to trial the new position in the patient's head, either with provisionals or a mock-up. So, determining the incisal edge position is an incredibly important thing for me as a restorative dentist. However, I'm going to show you 4 representations of post-op results where the incisal edges are in exactly the correct positions in the patient's face, and yet these are 4 failures because the gingiva is wrong in all 4. So this is the way Jeff and I look at it today. We start off by perfecting the gingival architecture, and then secondarily, we determine where the incisal edge can be. And as I've already mentioned, once you make a global diagnosis, you only have 6 tools in your bag of tricks to correct any tooth, gingiva, face problem. So let's start off with the first. This is the first perio tool, and this is where we add tissue. So we have a patient. She had porcelain veneer restorations placed on number 5 through 12 about a year before I saw her. And the veneers were starting to come off because they were prepped so deeply into the teeth that they weren't bonded well. So this is a case where we're going to have to take these veneers off and remake them. And since the preps were so deep, we're going to have to turn these into full coverage restorations. And since we're going to be restoring these teeth again, we're going to choose not to move the margins all the way up where they were before on number 6 and 11. We're going to graft those. So I'm going to remove the veneer and turn this into a full coverage preparation. I'm going to create a provisional and cement it with a permanent cement, and I'm going to send her over to my periodontist, Dr. Rendler. And he's going to do 2 connective tissue grafts on number 6 and 11 to cover those previously restored root surfaces. And we can see how beautifully the tissue is integrated around my provisional over those 3 months. Ultimately, we'll go back and re-prepare the other teeth and place the final restorations. So I think you can see how beautiful the result of the gingival surgery was that my talented periodontist created for me. So our first option is a perio option, and that is adding tissue or connective tissue grafting. The second tool that we have in our bag of tricks is crown lengthening, the second perio tool. And as we all know, there are two types of crown lengthening that are available to us. So let's first of all look at the aesthetic crown lengthening procedure. This is Adrienne. She's 16 years old. She's got a gummy smile, and she's got short teeth. We can see her central is only 8.5 millimeters long, and we can't feel the CEJ in the sulcus. So this is an easy diagnosis of altered passive eruption. The great thing about the aesthetic crown lengthening procedure is that it's always an easy post-op course. Generally, the patients only take Advil 2, maybe 3 days afterwards. The second great piece of news is we never have to worry about exposed roots, and finally, we never have black triangles with this procedure because it's only a palatal flap. We don't instrument interproximal tissue. So on the upper screen, you can see the flap and the bone position before the ostectomy. On the down screen, you can see that the ostectomy has been done and the bone's been moved 2 millimeters apical to the CEJ from line angle to line angle and thinned. That's our standard ostectomy. The tissue is then replaced so that it's 3 millimeters coronal to the new alveolar crest and it's sutured into position. And you can see the patient's going away that day looking better than they started. There's a little heme around the edges, but otherwise she looks better than when she started. And we're only dealing with healthy tissue, and so the tissue heals up very quickly, and you can see in the 6 weeks post-op, there's essentially no indication that we've been there and have done any surgery. However, the one thing you're looking at is that black triangle. And I just promised you a minute ago no black triangles, and now the first case I show you has one. So here's the question. Why does she not have a black triangle pre-op, and she does have a black triangle post-op? And I commonly get answers like the tissue is still healing, it will ultimately fill in, the contact is too far from the bone. All of those things are not exactly right in Adrienne. The reason that Adrienne has a black triangle post-op is because she had one pre-op also. You just can't see it because it's filled with plaque. And I'll prove it to you because there she is the day we did the surgery. There's the black triangle. So you never have to worry about creating a black triangle with this procedure. It just doesn't happen. So there's Adrienne before and after the procedure, and now with a much more mature and beautiful smile than pre-op. So the first type of crown lengthening and our second trick, the perio trick, is functional crown lengthening. Functional crown lengthening is much more aggressive. Functional crown lengthening means that we have to remove bone and soft tissue 360 degrees, apically position the tissue up on the root. It's a much more aggressive procedure. Who's it for? It's for a patient like Leroy. For reasons we won't discuss today, we decided that we were going to do full coverage restorations on Leroy's upper teeth. And we don't have enough clinical crown height for retention and resistance form. Therefore, we're going to have to create that height. And we're going to do it with functional crown lengthening. So we can see before the ostectomy and after the ostectomy, we can see this is a much more aggressive procedure than the aesthetic crown lengthening procedure we talked about previously. However, once we're done, we now have the clinical crown length that we need for retention and resistance. So on Leroy, I believe this was the right thing to do. However, anytime we do functional crown lengthening, we have to remember that there are biologic prices to be paid. First of all, we always have a root surface that we have to deal with as restorative dentists. Secondly, the tissue doesn't really want to be up on root, it wants to be approaching enamel. And when we move the tissue up onto root, it tends to heal with a rolled gingival margin. And commonly, when we put margins of crowns next to that rolled gingiva, we get inflammation, as we see in this patient. The third problem that we have to deal with is the roots get narrower as we move apically, and therefore the crowns become triangular shaped. The fourth problem is that since we instrumented interproximal bone and soft tissue, we end up with black triangles, and we either accept them or we have long interproximal contacts. And of course, the fifth problem is the increased crown root ratio. These always are issues we have to deal with when we do functional crown lengthening. So, those were the two perio tools, and that is add tissue or subtract tissue. The next two tools are the ortho tools, and those are to either intrude or extrude the teeth. This is Jeff's case, and I'm showing this case because it so beautifully demonstrates the use of both intrusion and extrusion in the canted patient. So, orthodontic appliances are placed in this patient, and teeth are going to be intruded from number 2 to number 10, and the only way we can get intrusion of posterior teeth is with this, using temporary anchorage devices. So these have given us the ability to intrude anywhere from 1 to 14 teeth. Today we can intrude a whole arch of teeth if necessary. So there's the patient after she's been leveled with horizon and then has received her beautiful porcelain restorations. I think this is very exciting dentistry because in the past, the only way we could have gotten this result was with a 2-jaw surgery and a multiple piece maxilla. And most of our patients weren't willing to go through that for this result. The fifth tool is surgery, and surgery includes extraction, implants, and orthognathic surgery. So let's look at the orthognathic surgery component. This is a patient that's got vertical maxillary excess. The two cardinal findings in vertical maxillary excess are long face and excess gingival display in the front and all the way to the back. So as we all know, this patient's going to go into orthodontic appliances to prepare her for the orthognathic surgery. She's going to get, at a minimum, a maxillary impaction. So here's a demonstration of it. Oral and maxillofacial surgeon is going to remove a piece of the maxilla and impact it. And once it's impacted, he or she will place rigid fixation. And in this demonstration, this is going to be a 1-jaw surgery, and so the mandible will auto-rotate into a good occlusal relationship. However, that's not commonly the case. In most of these patients, they're going to require a 2-jaw surgery. They're going to have a maxillary impaction and a mandibular advancement. So here's our patient who did have a 2-jaw surgery, and we can see now that her mandible has been advanced quite a bit. Here she is in a sagittal view with a very convex facial profile, and I think that's a lovely result in the sagittal view with a straight facial profile now. And here she is in the frontal, pre-op and post-op. So I think this is a wonderful procedure, orthognathic surgery, that's underutilized today. I think we should be paying more attention to the options that the oral and maxillofacial surgeon has for us as restorative dentists. So what I've shared with you today, briefly, are the 6 tools that we have in our bag of tricks to treat any interdisciplinary patient that has a tooth, gingiva, or facial problem. BOTOX is a wonderful treatment for this patient that has vertical maxillary excess. And the patient with vertical maxillary excess doesn't always want to have the orthognathic surgery, but they commonly don't like the gingival display. So for short, hyperactive upper lips, for VME, BOTOX is a great solution. So what we're going to do is we're going to inject a little BOTOX at the 2 positions that you can see on this demonstration at the ala on either side. So here's our patient. She has VME. She also has a short upper lip. She has excess gingival display, but she doesn't desire orthognathic surgery. So we're going to place a little BOTOX at the 2 areas where the X's are, and a few days later, this is going to be her biggest smile. And no matter how dirty the joke you tell her, that's as high as her lip can go because the BOTOX has limited the lip mobility. But the beauty is that we can still get facial expression after the BOTOX has been placed in the lip. She can show emotion, she just can't get her lip up where it was before. So again, these are the 6 tools that are available to us to treat the 4 global diagnoses that dictate all interdisciplinary treatment planning. This is a short view of a much longer program, obviously, but it's been my pleasure to be able to share my ideas with you today and this inspiration. So I'm Bill Robbins, and this is where you can contact me. Thank you very much.